So let's get started. I'd like to welcome everyone this evening. This is a surgeon education webinar, Restoration of Three-Dimensional Alignment in AIS Surgery, an Evidence-Based Approach. The webinar is presented by Setting Scoliosis Straight Foundation and the Harm Study Group, and we are sponsored tonight by Pacira Biosciences. Your moderators for this evening are myself, Peter Sturm from Cincinnati Children's Hospital, and Josh Pays from the Shriners Hospital in Philadelphia. Our guest speakers are Dr. Burt Yaszay from Seattle Children's, Dr. Michael Kelly from Rady Children's, Dr. Suken Shah from Nemours Children's in Wilmington, Delaware, Dr. Keith Bachmann from the University of Virginia, Dr. Dan Sucato from Texas Scottish Rite, and Roberta Brancone, Pacira's Senior Director of Marketing, is going to say a few words to us. Please submit all your questions through the Zoom question and answer section, not through the chat. Questions will be posed to the presenters by the moderators, and the presenter will answer at the end of each topic. This is our itinerary. Message from our sponsor by Pacira to start. Then we will do posterior osteotomies, goals and assessment of sagittal plane restoration, differential rod contouring and rod size material, direct vertebral rotation, and anterior release. Setting Scoliosis Straight is a nonprofit 501c established in 2018. Its mission is to better discoveries and advanced techniques and treatment of scoliosis in children and adolescents worldwide. Our vision is a future where children with scoliosis have the ability to live healthy, happy, and productive lives. And our first speaker is Roberta Brancone, Senior Marketing Director from Pacira, who would like to take a few words, say a few words to us. We thank Pacira very much for sponsoring this webinar.
Thank you, Dr. Storms. It is an honor for Pacira to be able to sponsor the symposium and to be involved with the Harm Study Group, who is doing so much to advance medicine and create a better future for children across the world. Pacira is delighted to be in a little way in helping you help your children with spinal deformities feel a little less pain from these very painful procedures. So, thank you for the opportunity.
And again, we'd like to give a special thanks to Pacira for sponsoring tonight's webinar. Our first speaker is Dr. Burt Yaszay, who's the Chief of Orthopedics at Seattle Children's, and he will talk about posterior osteotomies.
Great, thanks, Peter. So, I appreciate the opportunity and appreciate Setting Scoliosis Straight setting this webinar up and for Pacira's sponsorship. I'll be talking, we'll be just jumping right into probably one of the more maybe controversial techniques for AIS, and that's the posterior osteotomy. These are my disclosures. I think it's important to first acknowledge, I think we commonly use the term Ponte osteotomy or Ponte procedure for when we're talking about adolescent idiopathic scoliosis. But I do think it's important to highlight that Alberto Ponte, who described this in the 1980s, it really was meant for Schurman's kyphosis and the ability to shorten the posterior column. It really wasn't more widely used, at least from a kind of a AIS perspective and for wide posterior releases until really Harry Shufflebarger introduced it, specifically mostly for the Lenke 5 AIS curves, where again, it was an attempt to shorten the posterior column to ultimately induce lordosis. When we talk about these posterior releases, we're ultimately not talking about these curves. I think the controversy isn't necessarily there for these larger curves, whether they're AIS or other syndromic curves. It's really, the question is, what about these average AIS curves? And is there a role for these posterior releases from the perspective in terms of maximally correcting the deformity. And since we're talking about 3D, correcting it in 3 dimensions. The basis for the posterior releases really comes from this idea of where the etiology, or at least the understanding of the development of the scoliosis, and this concept that it's a relative anterior overgrowth that, at least in the thoracic spine, causes thoracic hypokyphosis, and that disproportionate relationship between the anterior posterior columns causes a buckling of the spine that then creates that 3D deformity. And our attempts to correct scoliosis is really an attempt to restore those normal anterior posterior relationships. So how does this, work for the Ponti procedure or posterior release in AIS? Well, the attempt is to basically detether the posterior elements of the spine. So you release the ligaments, facets, and capsules. So essentially that the posterior elements are no longer corrected, typically at the apex. And by increasing the spinal flexibility across the posterior elements, you can then ultimately increase the posterior column length. In terms of how this gets the 3-dimensional correction, it's because ultimately we've been driven very much in the coronal plane. And as we've kind of moved to more of this 3-dimensional correction, we've kind of learned that there's a consequence of kind of a one-plane correction on the subsequent planes. And so there's been concern that a coronal with axial correction could theoretically cause a loss of kyphosis. And a lot of our early papers showed, especially with pedicle screw instrumentation, where we got improved axial correction, that there was a loss of kyphosis. And the thought is that we're not really compensating for this in restoring anterior-posterior relationship. And here's an example, not a very big scoliosis, but a case of mine from about 15 years ago that really kind of highlighted and solidified this process. And so if you look, once the scoliosis is corrected, and especially when you look in the thoracic spine where it's kind of difficult to see, and especially when it's rotated, but I remember taking this fluoro shot, and it really highlighted to me across the apex where we kind of see this almost reverse wedging, which would, really exemplify this kind of change, at least between the posterior vertebral column or vertebral body and the anterior vertebral body. So it kind of reinforced this idea. So what about the Ponti osteotomy? And I'm going to introduce a little bit of this that's now probably been in our hands in terms of as a tool, the use of a bone scalpel or sonopet are the kind of the 2 devices there. And I have no specific conflicts with either of these 2 implants. But the idea is using this device to essentially release the bony elements in a way that actually allows us to kind of prevent releasing the ligamentum flavum until later in the case. And what you see here is really what the goal that's being attempted, and that is a complete disconnect of the posterior elements, both in its bony structure as well as its ligamentous or capsular structures. We'll get to a little bit of the data behind some of this, but the Ponti release, it is important to highlight that with any procedure we have to assess the risks associated with it. We can't operate and do things around the spine without understanding that, and I think this is where it's very critical. And I think where some of the controversy comes in is the risk worth the value of the procedure. Probably the biggest concerning risk, if not handled well, is the neurologic risk. Typically, this opens up the canal, especially when you're using spinal implants for something that has not routinely been exposed prior to the use of these posterior releases. And the paper down below has documented an increased number of neuromonitoring alerts in comparing patients that are AIS cases that had Pontis or posterior releases compared to those that didn't. One way to mitigate this is at the end of the procedure, one of the other concerns I had is whether these continued exposed elements would be at risk when placing bone graft. And this can be mitigated by various different techniques. Here's an example of a bone substitute that kind of cover those exposed posterior releases. The other risk is that there's a lot of epidural veins on the method by which you do the release. The patients increase loss, then obviously puts them at risk needing blood transfusion and so on, which can elevate us or blood products. Similar, though, there are ways to attempt to mitigate this, and Peter Newton from San Diego had a really nice paper showing that when using the harmonic bone scalpel, you can actually decrease blood loss associated with either the osteotomies or even just the facetectomies. So what are the supportive literature? Well, I mentioned before, Harry Scheffelbarger introduced this technique in the thoracolumbar spine or Lenke 5 curves, and he demonstrated in his early studies some improved correction and restoration of lumbar lordosis. This was actually before we really understood the three-dimensionality of what's happening in Lenke 5 curves. There have been subsequent papers, typically, non-randomized or comparison studies between historical non-Ponti compared to Ponti type procedures, and generally the papers by Pizzones and Shah both demonstrate improved coronal correction specifically. But like anything else that's controversial, there is other literature, and so these are some pretty strong literature suggesting that the Ponti may not be quite as what it is supposed to be in terms of either thoracic kyphosis or curve correction, and in some cases didn't quite correct the rib, which is a surrogate measure for axial correction. One of our illustrious co-speakers here, Dan Sucato, who I don't think is on quite yet, had a nice paper just recently in Spinal Deformity where he looked at slightly bigger curves. Interesting enough, he did demonstrate higher coronal correction rates, but very similar kyphosis between the curves that were around 70 degrees, and really were matched except for the fact that they either got a Ponti or didn't. And he also similarly documented a higher neural. I think the real question, though, and really assessing all of these papers, though, and really trying to better understand the role of the posterior release is, it is a tool, and like any other tool, there are a lot of things that we do to the spine to create correction, and the question ultimately is, are we using the tool to the best of the ability, and are we maximizing all the other things that go along with a Ponti? I can guarantee you that if I don't do what you're going to hear in Suken's talk and other things like that, if I don't do the right contouring, I can do as many Pontis as I want, and I'm not going to get the correction, especially in the thoracic or in the sagittal plane, as I want. So if we look at other papers that we see for risk factors for hypokyphosis, a lot of it is pre-existing kyphosis or the type of rod that we use, and then the other surgical techniques is like distraction techniques and contouring of the rod that really play a role in kyphosis restoration. This is a nice paper that kind of summarizes that, looking at kind of what are the various factors that are important for restoring thoracic kyphosis. And they looked at pre-op kyphosis, the surgeon, rod material, and posterior releases. And it really was only the surgeon that was the predictive factor. But I would actually say that likely represents a good use of the tools, including rod material, posterior releases, and appropriate bending of the rod. So as we consider and we go and listen to all of these talks, it's not just the application or the use of the tool or method or technique, but it's how we apply it and how we combine it with all the rest of the tools that we have to ultimately maximally correct AIS. So thank you.
Thank you, Burt. Great job. Really appreciate you sharing your expertise with us. I don't see anything in the Q&A just yet. So again, if you have any questions, just type them in the Q&A. We'll answer it now, or type them in and we can try to answer it through the chat. Type it in through the Q&A. Just real quick, Burt. So again, I know it's a controversial topic, but typically, is this something you perform on every idiopathic, or is it above a certain threshold, like above 70, above 80, or is it you're going to do it on all of them in an effort to try to restore proper alignment?
Yeah, no, it's a great question, and it's frequently even associated, especially with trainees, is how many do you do? The first is like, do you do it, and then how many do you do? I think it really comes down to, for me, assessing the sagittal plane. I think we walk into, the surgery and say, okay, this curve is a magnitude of 70 degrees. I'm going to apply more aggressive techniques, and I think that's fair. So from a coronal standpoint, things that are 70 or above, I'm probably doing more aggressive techniques like posterior column osteotomies. I think from the question is, curves that are smaller than that, do they all get one? No. And they're not, for me, up and down the entire spine either. I think it relates a little bit to what I'm seeing both preoperatively on the radiographs and then what I see on the table. I usually, if I ultimately decide to do the posterior columns, it's kind of in that lordotic portion of the spine where the patient seems to be, on the table, relatively lordotic, and typically I only address that lordotic section. So for me, the numbers of Pontes are somewhere between 3 and 5. So I don't have an exact threshold. So some of it's pre-op imaging and some of it's actually on the table.
Excellent. And then another question I had, because this has come up before, is like, what's your workflow? When do you do them? Is it do you do everything at once, all Pontes and screws and Pontes, or what's your workflow for someone who may not do this all the time?
Yeah. So that's a great question. And so for me, after the procedure and to expose the spine, basically bilateral facetectomies, I remove the cartilage from the superior facet. And then I will typically remove the spinous processes along the area where I think that I'm going to do the Pontes to kind of expose the ligamentum flavum. I do not get into the canal quite then. I do take the harmonic bone scalpel and then incise the superior articular facet, typically distal to where the capsule inserts on it ventrally. And then I put my screws in. And then after all the screws are in, check the screws and all of that, then I go back and I release the ligamentum flavum so that the canal is not actually open while the screws are going in.
Perfect. I think it's an important point to emphasize. For me, that's the same way I do it as well. So minimizing time the canal is open. Great. Well, thank you very much, Burt. Just in the interest of time, we're going to move on. Our next speaker is the illustrious international world-renowned man of mystery, Dr. Michael Kelly, who actually just graduated from high school, I believe, according to that picture, is now going to talk to us about global goals and assessment, sagittal plane construction. Dr. Kelly is the director of spine at Rady Children's in San Diego. Thanks, Mike.
All right. I got my timer up. My disclosures. My part of my the impetus for me thinking about this in peds and pediatric patients. This is one comment that we got, that this is a study that will get some love from reviewers because it reinforces what we do clinically. We try to get as much as we can and we see what happens. I hope that's not what we do. And then another conversation where I asked someone if you measured their pelvic incidence, right? In the adult spine world, you must measure their pelvic incidence. And the answer I got was sometimes. Why do we care about what is normal alignment? And you need to think about more easy biomechanical situations than AIS fusions, which have proximal and distal motion segments. The easiest way to do it is to fix someone to the sacrum. And if you fix them flat with undercorrection, it leads to increased juxtafusional forces with increased shear, and that is where you get PJKs. It also leads to increased strain at the lumbosacral junction, and that is where you get pseudarthrosis. In adolescent idiopathic scoliosis, these are very robust patients with healthy discs and strong musculature who can compensate for a long, long time. But I think if we leave them malaligned, they must compensate, and at some point that will come back to get us in the butt. And it may be when they're out of our practice, but it does not mean that we have mastered adolescent idiopathic scoliosis surgery. It just means that we are conflating a healthy patient with our bad surgeries. So is there any evidence that putting someone in a normal situation improves your risk of failures? Yes. So the graph on the left here, the x-axis is the deviation from normal of your lumbosacral alignment. And you can see that it's actually in this cohort of real patients, right? Theoretical was 0, but in a cohort of real patients, it was just north of 0, but you kind of want to nail it. Then those colored bars, right, are amount of malalignment of the thoracolumbar spine, right? The T4 to L1 pelvic angle mismatch. As that goes up, your risk of a proximal junctional failure or a pseudarthrosis also goes up in adult spinal deformity patients. However, for those of you who have never heard me rail against classifications before, classifications will tend to misclassify, and I do not know when a child becomes an adult and when adult surgery it's when pediatric surgery becomes adult surgery. It seems to be some arbitrary number chosen by hospital systems, and I think that the spine is agnostic to the age, and the spine wants to be in a normal alignment, which is what Dubois has always told us before. We also see here that problems are complicated, but malalignment leads to worse problems. So I think that helps us understand why we want to make normal alignment. Now, right, everyone talks about thoracic kyphosis. You just heard Burt talk about thoracic kyphosis. I dislike thoracic kyphosis because I don't know what that means. Thoracic kyphosis could be 20 degrees from T2 to T12, where all of it is from T2 to T4, or it could be spread over T2 to T12, or it could be T3 to L3, right, for like a Rousseli 1. And these graphs here show us that the concept and the TK, right, is the adolescent idiopathic scoliosis world. The thing we all hear about at the meetings and the things that you will see us analyze in our study group is PI-LL mismatch. PI-LL mismatch also means very little because the relationship between pelvic incidence and lumbar lordosis is nonlinear. The difference between the two decreases with increasing pelvic incidence. PI-LL is itself related to the PI because it's a nonlinear relationship, and the normal ranges are very extreme, you can see here, and not clinically useful. So it's totally useless to aim for a PI-LL mismatch when the variance between patients is going to be so high. So what we need to understand when we're talking about thoracic kyphosis and alignment targets and goals is that there's an arc of lordosis and an arc of kyphosis. The arc of lordosis and arc of kyphosis change with increasing PI. And as they increase, the upper arc of lordosis increases. So as PI goes up, your upper arc of lordosis increases. That lower arc tends to be relatively constant and necessarily equal to your sacral slope. And the thoracic kyphosis, you can see here, a type 1 is a low PI. Their arc of kyphosis goes T2 to L2. A type 4, very high PI, can actually have an arc of kyphosis that's T2 or T3 to T10 or T11, thereby showing us that we have two very different situations, and we don't really know what we're talking about when we say thoracic kyphosis and lordosis, which is why I like the idea of using the vertebral pelvic angles, which are the angle subtended from the centroid of a vertebra to the center of the femoral heads and the center of the sacrum. If you think about those centroids, all that does is draw a spline of the vertebral of the spine shape, where shape is dictated by both lordosis and kyphosis magnitudes, which is what everyone who focuses on TK talks about, but also distribution, which is what Rousseli has taught us. Now, looking at that, if we think about how can we measure this? How can we assess these angles? The L1 pelvic angle is actually very well predicted by someone's pelvic incidence. The R squared is 0.6, which means the variation or the variance around that line is pretty tight. It's 4 degrees, and it's about 50% of pelvic incidence minus 20 degrees for normal standing skeletally mature individuals. If you look on the right-hand side of the table, what you can see also here is that the T4 pelvic angle tends to be equal to the L1 pelvic angle. So now we know, if we know what their L1 pelvic angle is, in general, T4 is going to be pretty darn close to L1, and that gives you, by definition, a shape and magnitude of thoracic kyphosis to prescribe precision alignment, right? Personalized medicine, not some, oh, on average, we want 20. We're going to be able to give them exactly what we think they need. Now, you may say, Mike, these are normal standing adults, right? Look at the left-hand side is the normal standing adults. The graph on the right-hand side, L1 pelvic angle by pelvic incidence with an R squared of, this is, I mean, I'm a nerd, but I find this unbelievable, of 0.6. The LPA is negative 19, right, instead of negative 21, plus 0.5 of PI. This is 330 some odd pre-operative harm study group adolescent idiopathic scoliosis patients. The L1 pelvic angle is identical, irrespective of whether there's disease there or not. So this just brings us back to Dubosset's principles. And I definitely am over time. I don't have time for this. I'll take questions.
Mike, thanks very much. So we don't have any questions yet. So let me ask you, we don't see the problems of PJK and pseudoarthrosis in adolescents the way our adult colleagues do when they do deformity surgery. But is the take-home message that if we don't get this right when they're 14 or 15 or 16, as they get older, they're going to get into trouble?
I think so, yes. I think that we should be aiming for perfect alignment. And I think that saying that we don't really get, I mean, we don't get PJKs in part because their discs are not nasty and degenerated already, and that they generally don't get fixed to the sacrum. And getting fixed to the sacrum removes one of those pressure valves. But I definitely think that if we make them wrong, they compensate oftentimes through the lower lumbar discs. Oftentimes, if we are flattening the thoracic spine too much through this effort to create axial plane correction and coronal plane correction, I think we flatten the thoracic spine, and then they will actually flex through the lumbar spine a little bit, and I think it'll lead to earlier degeneration than if we can put them back into the cone of economy.
Okay. We still do not have any questions out there. So again, thanks, and we'll go on to our next talk. Our next talk is by Suken Shah, who unfortunately can't be with us tonight, so his talk is pre-recorded. Suken is the Chief of Orthopedics at New Moors in Wilmington, Delaware, and his topic tonight is differential rod contouring and rod size material.
Hi, everybody. I'm really sorry I can't be here live with you to participate in this excellent symposium, but pleased to be here nonetheless. What I'd like to talk to you about briefly are rod material properties, basically choosing and contouring the proper rod for your patient. So we'll cover correction mechanics, rod contouring goals, differential contouring, and rod mechanics. But we have to remember where we came from. This operation used to be done through a cast. They might have a 6-month hospitalization. Sometimes they had to re-explore the fusion to make sure it healed. Harrington rods were actually a revolution in coronal correction, but as we know, they did create a sagittal plane problem by flattening the back. Coronal plane was excellent, but frequently some of these patients fused to L4, L5, needed revisions in terms of 3-column osteotomies and complex fixation to the pelvis for revision. We can avoid a lot of that now. We're much better at assessing the scoliosis in 3D correction, safety, rapid recovery. I would say that progress has been made in segmental fixation and much newer implants. But strategies for deformity correction have always been a delicate balance between implants, surgical techniques, spinal mobilization or flexibility, correction forces. But through the evolution of modern instrumentation and techniques, these have been modified, developed, optimized, tested, and studied to be better and better than previous generations. Scoliosis is a 3-dimensional deformity, and we have to be able to assess all 3 dimensions: coronal, axial plane, and transverse rotation. And what we're going to concentrate on today is looking at that essential lesion or thoracic lordosis. Now, obviously, compression distraction used to form the mainstay of spinal instrumentation, where you would certainly lengthen the concavity and shorten the convexity. This has important implications for the sagittal plane. The rod derotation maneuver was thought to be effective in derotation of the spine and the apex at the axial plane. But later we did discover that it only translocated the apex. This rod rotation maneuver, when turning the rod 90 degrees, was supposed to result in an increase in kyphosis, but it actually just translocated the spine. Coronal and sagittal translation form the mainstay of most correction systems now, where the screws are engaged at the top and bottom. The rod is sequentially reduced to the apex, correcting the scoliosis, and dorsal translation of the apex helps with kyphosis. With slow correction and viscoelastic creep, we can actually derotate with special instruments. We now also have planning software where we can feed in the coronal plane, the sagittal plane, information about how flexible the curve is, create a 3D surface rendering, program in how much correction we want to do in the coronal and sagittal plane, and then create a plan that we can execute intraoperatively based on rod contours, posterior releases, and even implant strategies in order to get excellent corrections of coronal, sagittal, and axial plane malalignments, such as in this patient. And when taking the 3D surface renderings, we can see how effective some of our techniques are at restoring kyphosis as well as the axial plane. When we were using 5.5 rod diameters made purely of titanium, we were getting sagittal plane contours like this, where we didn't really restore kyphosis very well. And we certainly never want to do this, where we never actually correct the sagittal plane at all, or sometimes even make it worse. We've now evolved because we can do accurate assessment of the sagittal plane in 3D. And we have to recognize that the true lateral underestimates the true sagittal plane. The larger the curve, the more inaccurate this is. And you can see with further work that as the curve gets bigger, the more inaccurate our assessment of the sagittal plane is, such as in this patient who is not kyphotic at all, but actually very lordotic at each apical segment. Why does restoring thoracic kyphosis even matter? Well, it's very important in restoring lumbar lordosis, improving thoracic volume, avoiding PJK, and having a better cervical sagittal alignment as well. Possible solutions, just as we spoke about earlier, recognize the true sagittal plane and what your goals are for that patient. You might want to use stronger, stiffer rods, shorten the anterior column, which is not as frequent now as lengthening the posterior column with Pontes, posterior wide releases, or PCOs. This is a patient without any implants in, that just with the releases floated up into kyphosis intraoperatively. Is there a need for a routine Ponte? I believe so, because almost all patients need more kyphosis. We can lengthen the posterior column, which provides better coronal correction, axial plane correction, and this complete disarticulation of the posterior elements makes the spine more flexible for better 3D correction. This patient with apical thoracic lordosis received an excellent sagittal plane restoration and coronal plane derotation as well. And the same patient with the 3D renderings pre-op showing the apical lordosis, now post-op into apical kyphosis and an excellent axial plane restoration. What does differential rod contouring actually mean? It means there's a wide difference between the kyphotic rod on the concave side, which I'm turning now, and the relatively flat convex rod. Now, if I'm trying to restore thoracic kyphosis at the same time, I may want to increase the thoracic kyphosis and the convexity. But this is purely to derotate the spine, get rid of the thoracic rib prominence, and affect the axial plane correction. But still, we know the significant variability exists in contouring. These are 11 harm study group surgeons shown the same x-rays, and these are the rod shapes they came up with. They do not all perform the same, and that's why the variability exists. We have now techniques to customize 3D printed solutions for each specific patient, which may be helpful in the future. And it comes down to studying the structural properties of the rod. As we know, the stiffness is an exponential relationship to rod radius. And strength and stiffness with changing the material properties are very important, as well as the elasticity of a metal. And in this load displacement curve, you see that certain materials and certain rod diameters perform very well in terms of preventing rod flattening and resisting strong deformity forces. Because we all want a rod that will hold up to the contour that we bend. And we typically have to overbend kyphosis to even get some kyphosis restoration in very stiff lordotic spines. Some of the newer materials and larger diameter rods may perform better in resisting rod sagittal flattening, which then in turn improves kyphosis restoration properties. Bending yield strength, we want a stronger rod, not just a stiffer rod, to resist bending yield strength. And you'll see that as you improve rod diameter and change your rod material, this also makes drastic differences in bending yield strength. So I'll ask you now, what is the most effective factor in correction? Is it rod diameter, rod contour, the number of Ponte osteotomies? Well, according to the harm study group and our extensive research into the database, it's actually none of these in and of itself. It's the surgeon. It's a combination of all of these and a secret sauce that the surgeon pays attention to intraoperatively to execute kyphosis restoration. So in summary, each patient has specific goals. We have to develop a proper plan, do the intraoperative steps that we planned preoperatively, understand rod mechanics and when changing rod diameter material are important, contour those rods appropriately, but most of all, study our own behavior with routine 3D assessment. Thank you very much.
All right, thank you. It was a great talk by Suken. Really appreciate that. I don't see any specific questions yet in the Q&A section for that. If it's okay, Mike, if you're with us, I know you were going to kind of touch on it a little bit. Maybe just give us, I know you can't boil it down into one specific thing, but what are maybe one or two things you do for restoration of the sagittal plane? I know I won't even say thoracic kyphosis, so I know that's a but if you could just give us one or two things you might do to improve sagittal plane restoration.
I generally don't do osteotomies. I don't generally do like segmental derotation or on block derotation. I was telling them in the OR today that I remember when Mr. McMaster came as the SRS traveling fellow, like overlord, and we did an AIS and we had the whole contraption out and we're doing all this stuff. And he grabbed me at the sink later in the morning and said, "Hey, when you do that stuff, it looks cool, but it flattens the spine." And I said, "I have had my suspicions. Say more. Tell me more." And if you think about spinal balance with centroids, where the centroids create a spline of the shape, that in general, when you are doing that stuff, you are pushing the centroids ventral. And so if you want to derotate, you need to take the discs out. I don't think that the posterior column is the rate limiting step in segmental change. I think it goes back to what Dr. Sturm was talking about with these young, healthy kids with good discs, and the nucleus is created to be compression resistant. You need to get that out. And I think we have a talk coming up about, it's not really anterior release, right? It's anterior column shortening. And if you want to make them perfect, I think you need to shorten the front and not try to lengthen the back. I think if you try to lengthen the back only and improve the coronal radiograph, I think that's how you get into trouble. So I am much more willing to leave some axial plane deformity, some coronal plane deformity in a pursuit of a really nice looking lateral, because I think all of the motions are linked. If you think about how they got that scoliosis, it didn't happen that it deviated and then it spun and then it went ventral. It's all linked, and you need to uncurl that whole thing together the best you can. And if you want to make it perfect, I just think back to Peter's JBJS paper, where it shows that anterior column is way longer than the dorsal column, and there is no way that you can make an appropriate sagittal plane by just trying to lengthen the dorsal column.
Thank you. I appreciate that. All right, and that will follow up with Dr. Keith Bachmann, who is our Associate Professor of Orthopedic Surgery at the University of Virginia, and is going to talk to us about direct vertebral rotation. Dr. Bachmann.
Yeah, thanks. I'd like to really thank Mike for that great introduction to my talk, where he says that you shouldn't pay attention for the next 10 minutes.
Oh, no.
No, I'm kidding, Mike. I'm kidding. No, so we'll get to some of that, and I will echo some of what Mike was mentioning actually in that. So disclosures shouldn't end up being anything that affects this talk. Talking about direct vertebral rotation, and so this is, as Mike just mentioned, this is only one piece to the puzzle. And if you focus purely on the rotation of the vertebral body, even though we all talk about the rotation that's present, and certainly you look at rib humps, and that is something that patients are concerned about, if the focus is purely in that axial plane, you will likely not achieve the total restoration that you want, as Dr. Kelly just mentioned. And so it really is all of the topics that we're talking about. It's the differential rod contouring, plus minus the osteotomies, definitely sagittal plane, rod materials, and then if you have the gumption for it, anterior release, and then axial plane, personally, sort of the icing on the cake. If you can help tweak some of the other things and some of the other planes of the scoliosis deformity that you're working on by helping with the axial plane, then that may be something that is good. So scoliosis as this three-dimensional deformity, there is axial rotation. That axial rotation is most prominent at the apical vertebrae, as has been said throughout these talks, due to the relative anterior overgrowth of the spine. And the thought is that perhaps by addressing all three planes that we can improve the overall spine deformity or correction of the overall spine deformity. However, we'll talk a little bit about whether that holds true. So how you achieve this, the pedicle screws have given great three-dimensional control of the spine just by using the pedicle screws themselves. As was noted before, it unmasked the hypokyphosis. That means we're likely getting three-dimensional correction, axial rotation correction, just by use of the screws comparing to a posterior only structure. And you can see using some sort of connector, whether you want to do segmental on block, some way to connect the screws to try to control the screws and thereby the vertebral body to gain correction. Note in this picture, there's also some distraction happening, and this is after the rods have been bent, as was mentioned previously, that special sauce that a surgeon may have in terms of their rod contour. And so when you look at direct vertebral rotation, maybe fine tuning or harnessing the power of the screws, leveraging that three column control of pedicle screws to gain correction through restoration of three-dimensional anatomy. The question is, does it work? So here's a smattering of studies, and if you hone in simply on the rotation of the vertebral bodies, the answer is yes, it works. This is a study that was out of the harm study group looking at, instead of getting CT scans, can we use the geometry of the x-rays and the screw position on x-rays to determine whether that correction worked in the axial plane? And the answer is it works. You can see some papers, D. Silvestri, 63% correction of rotation on CT versus 14% without. The LAL, 14% grade 2. Those are the screws outside of the rod with derotation maneuvers, compared to 51% if you did not do direct vertebral rotation. Penkowski showed that single concave rod rotation leading to 16% increase in the apical vertebral rotation, while direct vertebral rotation led to 32% improvement. And Lee with Professor Suk, 42% correction with direct vertebral rotation, 2.4% with rod derotation. Despite the increase in hypokyphosis, I think the screws themselves and the unmasking in 3 dimensions are likely occurring whether you attempt to do direct vertebral rotation or not. However, with direct vertebral rotation, mean decrease in kyphosis in a study by Dr. Cahill and colleagues, 5.1 degrees compared to 10.8 without the DVR. So I think the unmasking of the hypokyphosis is present, whether it due to the scoliosis and due to screws, not necessarily due to direct vertebral rotation. And that dovetails with the talks that have been given about really the focus is on all 3 planes, and whether it's doing osteotomies posteriorly to try to get sagittal correction, or really focusing on your rod materials, your rod diameters, and really honing in on those centroids of the vertebral bodies. How do you get that sagittal plane restored? So then the question is if you do direct vertebral rotation, is it long lasting? And the answer is it not necessarily for everybody. There's been multiple studies now, especially more recently, showing longer term follow-up, some of these getting out to decades later, that are demonstrating that the rotation at the apical segments seems to fade back to where it was, likely reflecting slippage on the rod. Maybe it reflects the lack of differential rod contour at the time that these procedures were done. And so I think, again, just highlighting that we're probably not getting what we think we're getting when we do direct vertebral rotation maneuvers. It's not going to be the only piece to the puzzle in terms of obtaining correction for these patients. And so the highlight for me, as you dig into literature about direct vertebral rotation, I think it speaks nicely to what the goal of this entire talk and these presentations are, which is that you really need to be thinking about the deformity in all 3 planes of deformity. There's not one technique that we're talking about that is going to quote unquote win the day when it comes to scoliosis correction. So it's focusing on all of the planes and then finding techniques that work for you and really attempting to refine those techniques. Dr. Shah talked about measuring in 3 dimensions and looking to ensure that you are continually undergoing process improvement to try to improve for these patients. Recent study looking at the disc change, evidence of degenerative disc disease. This is ahead of print after pedicle screw instrumentation with direct vertebral rotation. The key factor that led to advance of their degenerative disc disease was preoperative hypokyphosis. Nothing to do with the rotation of the vertebral bodies, correction from the vertebral bodies, that sagittal plane coming through again that Dr. Kelly had talked about. Thanks.
Steve, thank you very much. Good talk. Looks like we don't have any questions at this point. Let me ask you from a technique standpoint, when you're doing your rotation, how do you make sure that you're not pushing down too much on the convexity? Because I think that's the big concern about decreasing the kyphosis, is as you bring it around, if you're pulling up on your concave side, pushing down on your convex side, if you push down too much, you're going to flatten things out. How do you avoid doing that?
Starting with the rod bends, I would say that looking at the images that Suken had, some of the early differential rod contour for me was a relatively flat rod on that convexity. I've gone to more of a relative differential rod contour, still trying to gain kyphosis on that convexity, looking from a planning standpoint, trying to gain more in the concavity, but you know, still less in the convexity, and then attempting to pull up. I'm more in the camp of what Dr. Kelly spoke of. I don't focus as much from a derotation standpoint. I'm okay with sacrificing a little bit in the coronal plane. So I was a little tongue-in-cheek giving him grief in the intro to that. And so I think that your point is a good one. You really don't want to flatten when you're doing this. And if all you're doing is exposing that anterior overgrowth and bringing that centroid to the middle, you're probably going to be making it harder for yourself to correct the deformity, not easier for yourself to correct the deformity.
Thanks. And we do have one question. What practical approach do you recommend for rod diameter and material? And that's to all the speakers. Keith, you want to start with that?
Practical approach. I would say that in general, you need to pair your bone quality with the purchase that you have from an fixation anchor point standpoint, and pair that with your rod material, and then understand your rod material. So the thicker rod you're using and the stiffer the rod that you're using, then you don't need as much differential contour. You need to have an understanding of what those rod materials will do when subjected to the force of the spine. So bending bigger for rods that are not as stiff, and not needing to bend as much for rods that are stiffer. And then I find that working with the same rod material every time allows you to have that repetition of how that rod will respond to the spine. So trying not to mix it up as much until you have a good feel for what those rods are going to do.
Mike or Burt, any take on that?
Since coming here, I moved to 6.0 titanium. I do like that it's got a little bit more give. I grew up, I was born and raised on 5.5 cobalt chrome. I think for me, one of the big changes is I have switched for the most part to a medial basted posted system. I really hope that as we get to precision medicine for this spinal fusion stuff, that I think we may look back at tulip heads and kind of chuckle, kind of like BAK cages. And again, you know, maybe I'm a dinosaur, but I remember sitting next to Rusili and saying, like, what rods do you use? And he looked at me and he said, Mike, they're going to try and sell you a new rod every 3 years. Just do good surgery and it'll be all right. And as long as you're not using like silastic rods, you're probably going to be fine.
Okay, thanks. I think it's time to go into our last talk. Our last speaker is Dan Sucato, who's the Chief of Staff at Scottish Rite Hospital for Children in Dallas. And he's going to talk to us about anterior releases, the restoration of three-dimensional alignment.
Great. Thanks, Peter. Can you hear me?
Yeah, we can.
Okay, great. Thanks. Love all the talks, learned a lot, agree with most of what everybody said. So I have a little disclosures in that Globus with royalties on a small product. My big disclosures, I love anterior surgery. So obviously the goals of spine deformity correction is obtaining correction and then maintaining it over time. And then safety, of course, is the most important. So the agenda really For me, anterior release is not used very often in idiopathic scoliosis, but completely agree with Mike in shortening the anterior column, lengthening the posterior column. And when you can't do that all posteriorly, then having in the toolbox an anterior release to allow you to shorten that column, I think is really important. So I'm talking a little bit about technique indications. You'll use some other cases to raise the sort of awareness of the techniques. And so obviously the greater correction with stiff curves, you need to employ different techniques. So all these 5 patients are idiopathic scoliosis. And so we use different techniques when you get to big curves like this. The 2 middle patients had an anterior release of the posterior fusion. No posterior osteotomies, and we gain good corrections. This is what they look like before surgery, and I'll show you a couple patients after surgery. After surgery. So, anterior surgery, like someone said, is probably the best way to get axial plane rotational correction. So this is an old slide of an anterior 5C curve that was done with a single TSRH rod with anterior cages in the front. You can see we start at the top, and you can see you can rod rotate and get beautiful lordosis, beautiful axial plane correction. And more modern in terms of doing it anteriorly is a dual rod system, works beautifully, gains beautiful correction in all 3 planes. And oftentimes you can go a little bit shorter. You can see a little disc wedging at 3-4, which is oftentimes we accept. And don't forget about anterior thoracic surgery. We used to do this a fair amount. This is a thoracoscopic anterior fusion, stopped at T12. And for sure, if I did this posteriorly, I wouldn't even come close to stopping at T12. So anterior surgery has some real benefit, and you can get some nice correction, as you can see in this young lady before surgery and after surgery. So speaking of hypolordosis, so here's a good patient. This is a perfect indication for an anterior surgery. This is not obviously idiopathic scoliosis, but you can see that concave rib and the amount of lordosis in this patient. You can almost see like there's a bar on that concave side on the APN, actually on the lateral, because of the rotational deformity. So this is a perfect indication. She's also fairly young, and so you can see her triradial cartilage is open for an anterior release. You can see this is a beautiful illustration. It's a little rotating a little fast, but posterior fusion with anterior growth. And when you look at this 3D CT, oftentimes you get a little bit of volume averaging, and so it overestimates the amount of fusion in the front. And so we went anteriorly on her, and this is looking down from proximal to distal. You can see to the right there, those knuckles, those are obviously the rib head. And you can see distally, we have single lung ventilation on this particular patient. And you can see the amount of lordosis with the disc bulging out there. And so this is a beautiful indication for an anterior release. For the sake of time, this is an older video of just an idiopathic patient where I still do this today with using a 15-blade knife, and really can get all the way back to rib head, push the pleura back with the back edge of that knife, and you can, understanding the anatomy where the ribs are, you really can get a nice anterior release and get all the way back to posterior annulus. You cannot get PLL. Anybody that tells you can do it thoracoscopically is not telling you the truth. I do a lot of anterior surgery, and I cannot get back there safely. If you have to take rib head, which we did on this particular girl, it's very easy to do. Reflect the pleura back, coagulate any sort of bleeders around, and then just using rongeur, really take that rib head back, which I think in very severe curves, not necessarily idiopathic scoliosis, is necessary. When you're landing screws for a tether or an anterior fusion in the front, you do have to take, at least for me, take rib heads back at the T5 and 6 level, and T4 if you're going that high. So I do anterior releases generally in the prone position through a thoracoscopic approach. Some patients who are a little bit smaller and a little bit more challenging have to do them in the lateral position, like this patient with neurofibromatosis who went to T1, T2 through this axillary portal, which works very well. Here's a patient with a congenital curve, really didn't have many posterior elements as a triradial cartilage is open. Again, did him in the prone position. You got nice correction, and you can see the anterior fusion in the front with an anterior release and fusion. You can see overall pretty good results. Here's a patient with neurofibromatosis, just to show the kind of things that you can do through the scope. And so you can see she has very little posterior elements, no pedicles in the front. This is a patient of one of my partners who had growing rods and things, obviously in kyphosis, really have challenges. And you can see that she has implants that are pretty prominent. And so he went higher after a little bit of traction and went into the cervical spine, but she was left with a lot of kyphosis. And so this is through the scope, looking up apically. You can see the vessels pulsating, and there's the apex right there. And so it just doesn't make sense to take the disc. So we put a rib strut graft And you can see here to the left, we're taking out the disc where we're inserting it, and distally we did the same. Then we measured it with this stylet. And then we took the rib through these small incisions through the thoracoscopic approach in the lateral position, and then put a rib strut graft. So this can be done. You know, it takes a lot of time and experience to learn how to do it. You can see that rib graft actually stayed pretty nicely over time and actually hypertrophy. So now for the idiopathic indication. So there's a 9 + 3-year-old boy whose MRI was clean despite his left thoracic curve. His triradial cartilage is open, and so he had an anterior release and a posterior fusion. I did this kid a long time ago. He's now 20 years of age. You can see his PFTs, by the way, when you do it thoracoscopically, has no detrimental effect on pulmonary function. We have 2-year data that we've recently published. His SRS scores were very good, and here he is at 20 years of age with nice correction. Could you have done this all posteriorly? Perhaps. You can see his thoracoscopic incisions there are hidden very well. Here's another idiopathic patient I did some time ago, 125-degree curve. You can't really see it, but she's also very lordotic, and so she was done in the prone position in a posterior fusion instrumentation, and today you perhaps could get that all posteriorly, and here she is. You can see this was some time ago. It was her iliac crest bone graft site is evident there. So this is a more recent case. So this is a boy. You can see his lordosis not only radiographically but also clinically, and so he's very hypokyphotic. He's lordotic. He's got a huge rotational deformity. So for him, I do an anterior release, and this is this rod link reducer we developed and is marketed by Globus. It's a nice way after the anterior release, all done in the prone position, to go posteriorly. And we pushed, this allows you to sort of lengthen and unhinge that apex, which then allows you to put this rod in on the left and really do this differential rod contouring, which has been around for a long, long time, including back in the CD days, where you pull the apex to the spine and really get nice three-dimensional correction with an anterior release. We also did a thoracoplasty on him, which I think has some utility in these really severe curves, and you can see his clinical appearance there. Overall, pretty nice result. So in summary, I think an anterior release, it's relatively uncommon in AIS. I think the best indication are severe 3D deformity, as everybody's mentioned, especially the hypokyphosis and really low lordotic spine. You got to keep your experience up with anterior surgery. Younger surgeons today probably aren't exposed as much as we were back several years ago. And so got to keep your experience up with congenital NF cases. And I think there's varied options for rod diameter metal, et cetera, that everybody's mentioned. And the options for correction have been really the rods, in my opinion, and have been the game changers with respect to correction. Thank you.
Thank you very much, Dan. You are truly the expert in this field and really appreciate your time. I know you're very busy, so thank you. A quick little story. I was the very first or second cutting edge course in Miami with Dr. Shufflebarger and Harms, and Larry Linke got up and was talking about I haven't had to go anterior in 10 or 15 years. And Jensen gets up, who was Harms' #2 at the time, and he says, Dr. Linke, how can you say you never need to go anterior when your results are so inferior? Which created a very nice discussion after that. So that was great. Anyway, real quick to you, Dr. Sucato. What I know you kind of touched on at the end. I'm glad you did. As I think, we've moved more in the posterior. That's certainly what I do a lot more of, or all of, except for the growth modulation. How do you get that experience? Do you recommend starting with an access surgeon and doing your first one on a less severe curve with someone else? You do it open to start. Do you recommend doing it thoracoscopically with an access surgeon, or try it yourself? Or what's the best way for someone to get out and try it who hasn't had any experience to date?
Yeah, it's a phenomenal question, Josh. I was lucky because I sort of grew up in the sort of anterior age, and so kind of gained experience along the way. I think it's very difficult. I mean, if you ask our fellows that go out who are only doing spine, the number of thoracoscopic or anterior surgeries that they do is it's going to be in the teens, maybe in the 20s, maybe. And so, I think if you're going to be the person at our place, and I'm passing this on to others because I'm not going to do this forever, but I think you got to have the experience of partners who can send you cases. But I think you got to spend your time in the pig lab. And so, I did it under the guise of research and just operated on a ton of animals. And, and our data, I think, was pretty good, what we published, but really it was an unbelievable experience. I mean, you got to be dedicated to doing it. I mean, today in spine surgery, if you really want to be a top-notch spine deformity surgeon, you got to practice, and you got to kind of hone your skills in the lab and visit people. And you know, I didn't visit many people. I sort of developed my technique in the lab, but visiting people today who are doing them, I think obviously you pick up pearls along the way, and talking to people, and you know, it's old fashioned hard work. That's the only way you're going to get it. In terms of an access surgeon, again, I don't know, you guys can comment. I mean, at our place, I don't use an access surgeon for any thoracoscopic cases. I at one point sort of struggled with that, and then had them come in, and then they just do things differently, and it just didn't work very well. But I think obviously safety is number one. At our place, you know, we don't have general surgeons down the street. So we have them down the street, but not down the hallway. And so it's you know, you got to really sort of think about safety is always number one. For open approaches, you know, some of the folks use them. If it's a really hairy case, I will use them too. If it's a you know, kid who's got thoracoabdominal previous surgery, you know, I'll use them too. But on a primary, you know, and again, I don't go thoracoabdominal very often these days. Occasional tether, but that's it.
Excellent, thank you. That's sound advice, and you know, it's good to say that you practice on pigs before you practice on kids. I think that's wise words. But thank you very much. Real quick, Burt or Mike, I'm not sure. I know you guys have done some anterior work as well. Access surgeon, no access surgeon for you, and then we'll close it out.
My access surgeon's Peter until I'm allowed to do them by myself.
Yeah, our institution, we use an access surgeon, but I think, but they're a good assist.
Keith, you use it or no? Oh, awesome. Still there, Keith?
Oh, was that for me? Sorry. Access surgeon. Yes.
Perfect. All right. Thank you very much, guys. So I get run a little short on time, so we'll close it out. I really appreciate everybody joining us today. And if you really enjoyed this webinar, there'll still be more to come. If you're grateful for this event, please consider donating to the Setting Scoliosis Straight Foundation. You can go to our website or text scoliosis to 41444, and your contribution will support our surgeon education programs. We're super grateful for that and all of our industry support as well. As we'd like to specifically thank Pacira for sponsoring our webinar today. You guys have been tremendously helpful in advancing our research, but also our educational opportunities as well. So thank you very much. One more, I believe, Harvey. There we go. So there's definitely some more educational events coming in 2025. Check out our website below, settingscoliosisstraight.org. And then there'll also, you guys will receive a survey coming up. If you could please fill that out, send it back to us so we can improve upon the next webinars and educational events to come. That'd be great, so you guys can have a good experience. So I'd like to personally thank Dr. Sturm, who did this on short notice, for moderating today, Burt Yaszay from Seattle, Mike Kelly from Rady Children's in San Diego, Suken Shah from Wilmington, Delaware, Keith Bachmann from UVA, and Dan Sucato for TSRH. It's been a real pleasure, and thank you all for your time and sharing your expertise, and I look forward to seeing you guys at the next event. Thanks again.